Welcome, everybody. Could we throw up the first slide? Is that possible? She made it. We're going to talk about the issue around immune therapy or PD-1 therapy Rechallenge, not immune therapy hands, because I'm not going to wind you up to start with. Because immune therapy is not PD-1 therapy, because there's CTLA-4 as well. And I'm looking forward to that debate, which I'm going to move the slides on if that's possible. Do we have a slide? Fabulous.
No, go back.
Go back about 7. Who wants to start? Toni, would you like to start? I think you were involved in CONTACT-03, is that right?
I believe so.
You were indeed.
My hazard ratio reached your old studies hazard ratio.
Why don't you talk to us about when you first designed CONTACT-03? Did you think it was going to work? And with hindsight, what would you have done differently?
So I was with Mike Atkins. That's the story.
You're blaming
Mike Atkins. Yeah, 6 years ago, we were at the Commonwealth Hotel. There was a SPORE meeting. Dave McDermott was there, and Mike, just was specifically eating. So I came to him and said, Mike.
Was any of it your fault, Toni, or was it all Mike?
Was what?
Was any of it your fault, or was it all Mike?
No, it's all Mike, always.
Right.
And I said, Mike, we're seeing a lot of things in people continuing IO, switching to TKI, etc. I looked up the literature, and in lung cancer, bladder, melanoma, there is no data. Because, Mike does melanoma. No one did that. Like, why do you do that? And Mike is like, it's a question that needs to be answered clinically, and I don't know what it is, but it's a question that needs to be answered clinically. And we started asking
Why did you pick atezolizumab?
Why it need to answer quickly?
Why atezolizumab? Why did you pick atezolizumab? Was it because PD-1 was...
Because in this study, we wanted a drug that didn't win, that is active.
Yes.
So 25% response rate at that time from David's study in untreated population. And second, we want a drug that wasn't used as a first line, and Nivo and Pembro were killing it. David's drug wasn't killing it. So
it's partly David's fault as well.
It's David and
Mike.
And Mike.
Yeah, so far, okay, we've got two culprits.
We said, and maybe switching from PD-1, PD-L1, so we designed CONTACT-03 with Laurence, Monty, and others.
Lots of people.
The rest is history. I'm going to stop.
Okay, and what about TiNivo-2? Who wants to describe how that, who wants to talk about that study and how that came about?
So Laurence and Laurent led the initial study, TiNivo-1 or something, with an untreated patient, in PD-1 naive patient. There was activity. And at that time, when CONTACT-03 was doing, people were like, you have to use a PD-1 inhibitor. And who told you that you should switch to another drug? And at that time, all the OS benefit from axiavulumab and from emotion came down. Initially, we wanted to combine Pembro. But then there was no phase 1, so we went with TiNivo.
And why did you pick a lower dose of tivozanib? Was that a concern at the time?
Yes.
Because we did have data kicking around suggesting that dosing of VEGF TKI was relevant.
It was situational.
What does that actually mean?
In English?
I don't know what that means.
Yeah.
Was that Mike's fault?
No.
Whose fault was that?
That was Jim Meyer, the trio, the third. No, at that time what happened is that, believe it or not, the FDA was starting Project Optimus. That the dose is so important, and there was emerging literature that I wasn't too familiar with because it was published in a non-oncology journal that among all PD-1, PD-L1 inhibitor, nivolumab causes hypertension. Don't ask me why, but it's true. And I'm like, well, based on what? But and the FDA picked on this. They looked at Laurent's study. They looked at the first 10, 12 patients we enrolled, and they said, well, the grade 3, 4 are higher than you think. You need to, we could have said no, but you can't say no to the FDA. We need a lower study. And at that time, the Cabo 40 was Monty, and Cabo 60, and Cabo Nivo 40 was going, so we ended up with going with lower dose Nivo. The hypertension at that time was concerning. If this is to repeat again, Project Optimus wouldn't be as much in the middle of it, and I think we could have gotten away with full dose.
And is that why you think your hazard ratio is 1.1?
No, that's because being close to you, I'm getting these hazard ratio. Yes, it's 1.12.
Yes.
Not good.
Well, not necessarily bad, but do you think it's actually worse, or do you just think it's noise?
No, I think it's noise. Probably the lower dose of TiVo is worse, but not to a degree that make completely nivolumab, like some people, few said that if TiVo was higher dose, Nivo would have done better. I disagree.
It didn't make the trial negative.
No, it didn't make the trial negative.
Were there any conduct issues in either of these trials that would have been positive and negative? Sometimes you get trials wrong, there's censoring, there are lots of problems. Are these both clean? I mean, they're both published in The Lancet. Are there problems with these studies?
So they're both clean in terms of the majority on CONTACT-03 are clear cell, TiNivo-2, all clear cell. What TiNivo-2 did something, and I think I'll give credit that to Mike. I called Mike, if you remember. He's like, well, maybe you shouldn't have had progression while on PD-1. What if you have another TKI and then you get, these patients will do maybe better. Actually, Mike was wrong, and these patients did the worst. They had the same PFS of 3.7 months, but that was an important question to ask.
Poor Mike's taking a beating, but that could just be because it was third line versus second line. Though.
Could be,
right.
could be.
But yeah, I hear you.
I listened to Mike, and
Mike's going to grab the microphone in a second. David, what's the biological rationale for Rechallenge with immune therapy?
It's limited. So if you think of patients who start on immune checkpoint blockade with PD-1, they come off for several reasons. One, most commonly, is progression while on drug. The other is, if they have a great response or they get to the end of a course of, say, 2 years and come off therapy. Some come off for toxicity. So had you enrolled patients on this study that came off prior for toxicity with the prior regimen, or had come off, 2 years of treatment and, for whatever reason, waited a couple years before entering this study, you might have seen a difference in some of those patients. But most of these patients had recently prior PD-1. And we know that while the half-life of PD-1 is relatively short as an antibody, 2 to 3 weeks, it sticks on your immune cells for months. So most of these people were on both arms were probably still on PD-1. So the result, while important, because hopefully we'll all take it and stop giving PD-1 after PD-1, it's important for clinical practice. It's completely expected. But it also is important for the next big question, which is not so much these trials, which will hopefully limit practice, but what do you do in the adjuvant setting? And that gets back to the question of, is there such a thing as PD-1 deficiency, PD-1 blockade deficiency? And the answer is there probably is.
Describe what that actually means.
Okay, so in the early days of PD-1, this was when you were in high school, you could only give PD-1 for a certain amount of time. You had to stop at 2 years. Actually, the initial trial, which is led by Julie Bramer, JCO, you could only get 1 dose because people were worried about explosions of lymphoproliferative disease by blocking PD-1. So you could only get a second dose if you were benefiting from the first dose. So we went from 1 dose on Julie's trial to 2 years, which was completely arbitrary, picked out of nowhere. But the interesting part about those trials, both with Pembro and Nivo, is if you look at what happened to some of those patients after 2 years, meaning they made it that long and then stopped, depending on the disease, they did different things. So in the case of melanoma, 90% of those patients stayed in response off drug. In the other tumor types, it was less than 90%. And that variability, that intratumoral variability, needs to be better defined because there are probably some patients with kidney cancer, maybe even with bladder, that might need continuous PD-1. If you ask me what the percent of that patient population is, I can't give you an answer, but it's probably not 0. But it's different based on different diseases. And it is in that group of patients where reinstituting PD-1, I think, after adjuvant PD-1 might make some sense. But we need to define what that is.
But you don't think, have these trials been done in pick whatever population you want, that they would be positive?
No, because that population is so small.
Yeah.
You couldn't enroll that trial. This result is exactly what they should have gotten. If anything, the TiNivo trial proves that lowering the dose of the TKI probably limits
Yeah.
the impact of the therapy. And that's actually also potentially an important concept for us to think about in future trials, because as many of us who use VEGF PD-1 combinations know, they're either not starting out on full dose of VEGF blockade in some of those regimens, or we're lowering the doses of VEGF in other regimens, often significantly. So if you look at what, particularly in the community, how much of drug X they're giving, it's often much less than the label suggests, and you're probably limiting efficacy when you do that.
Tian, what's your take on this story?
You know, what strikes me is that these were all kind of unselected patient populations, and what we have been behind on in solid tumors and kidney cancer is that we don't have a lot of serial time monitoring for our patients, unlike the lung or breast populations where we know what resistance looks like, right? And so I would love to be in a future state where we're thinking about what is actually happening for IO resistance, and to try to tackle those mechanisms of resistance. To me, what these trials speak to is that we're just in a black box in terms of not understanding IO resistance, PD-1 resistance.
Is there anyone, Tian, who you would read? So let's see if frontline axi-pembro, progression of disease after 12 months on both drugs. Is there any time or any place where that patient will ever receive immune checkpoint inhibition again?
I mean, we have these patients now, 4, 5, 6 lines in, and so if they've had a really nice frontline response, and now they've had, a couple of serial TKIs, they're more than a year out, where we think their T cells are completely exhausted, and they're, maybe in a more sensitive setting, could we perceive the chance that that patient might, re-challenge?
You said so there's a year gap for you, a year off VEGF targeted therapy, maybe re-challenge. David?
So you said, would you give immune checkpoint blockade to that patient?
PD-1, PD-L1, sorry.
Oh, yes, so I think we need to be clear.
Yes, I'm saying PD-L1.
We're going to get to CTLA-4 later.
Okay, good, I can't wait.
We're coming to CTLA-4.
We're on slide 1, so.
So we're coming to that. So PD-PD-L1, not immune checkpoint. Obviously,
good.
OX40
Yes.
and TIM3 and all. Toni, what's your take? Ever re-challenge anyone with advanced disease after a year of axi-pembro?
Yeah.
When?
A year is my time.
A year gap, you have another go.
A year gap.
Despite all of the evidence from these two studies, these huge undertakings, you're going to have a second shot of the dice. And what's the biology behind that re-response?
I don't know. This is my decision.
There were early trials, BMS did them, where, Nivo-treated folks, they did very nice T cell modeling, and the T cells stayed active for about 6 to 9 months after a single dose of nivolumab. And so that's where I base my premise of, maybe a year later, they might be resensitized.
We've done two big randomized trials. They're both negative. They included these patients. Do you think someone in the audience who's, let's say they do different type of cancer, or even they don't even do cancer, they do lung disease or renal disease. Let's say these oncologists, they've done two big randomized trials, completely negative, and they're all re-challenging.
Just to be clear, a year from adjuvant. You asked
No,
adjuvant?
I'm asking a year after first-line axi-pembro.
Yes.
First-line axi-pembro progression.
So you shouldn't do it. If someone comes off therapy, if they're on PD-1 and it progresses on therapy, they shouldn't see it. There's no reason to expect that the second PD-1 to do anything. We wouldn't give Rituxan after growing through Rituxan. We wouldn't give, EV after someone blew through EV. We shouldn't do it with these drugs, even though they're easy to give and we want to believe that they're active. It's wishful thinking after someone progresses through therapy.
Totally agree.
Yeah,
So Toni, I'm going to ask you the question again. In metastatic disease, re-challenge.
Correct. The only thing I do is Nivo-Ipi, but don't do CTLA-4. We're just a slide.
We're not talking about CD4, we're talking about...
no. The answer metastatic,
pembrolizumab,
I do not.
So Tian, you've got a bit of uncertainty in your mind, but Brian, I'm guessing I know what you think.
Yeah, I wouldn't treat anybody with PD-1-based therapy. I think it's totally made up. Right? It's wishful thinking, right? I call it faith-based medicine. Like, I hope it works. I want it to work, but there's not a shred of evidence it does.
There's a lot of evidence it doesn't.
No, there were 3 toxic deaths on CONTACT-03, so there are consequences to this.
I mean, at least mistletoe...
CTLA-4 is, I think, a different question we're going to talk about in a few slides.
At least mistletoe we don't know.